Good morning, guys. This is Bridge Carmore, one of your hosts from SABCR Brain and Health Talks. I'm here with a very special guest today, and we'll be learning more about childhood cancer from a doctor's perspective. So I'll let the doctor introduce himself.
Hi, my name is Mihir Bhatt. I am one of the fellows in Pediatric Hematology Oncology program here at McMaster Children's Hospital through McMaster University. In my training, I have completed medical school here at McMaster University, followed by training in general pediatrics for 3 years, after which I have entered the fellowship program. In the fellowship program, we currently learn about the hematological disorders in children as well as cancers and how to treat those. So I'm very honored to be a part of this talk program.
So, when you talk about hematology and, oncology, and so in very common terms, what exactly does your job involve?
So hematology stands for blood conditions and disorders. So study of blood cells, there's different types of blood cells and components and diseases related to that. So we focus on patients who have those conditions. Something commonly you may have heard of, for example, is anemia. That's one of the blood problems that children or adults can face. That's common problem that we see, but there's many other different types of blood problems that we encounter in our clinical practice. Mm-hmm. On the oncology side, it stands for mainly childhood cancer. It involves everything from blood cancer such as leukemia to brain cancer to solid tumors, including tumors of the kidney, liver, muscle, etc.
And in that, do you ever get to see any patients with brain tumors?
Yes, actually, CNS or central nervous system tumors are the second most common childhood cancers. The first being leukemia, and the second being brain tumors, and then the rest.
Okay. So just to go into a little bit more about your work, when you talk about being part of the treatment part of it, on now we get to see what the other side of things are like, from a doctor's perspective. So what is it that you would describe as the best part of your job, or when you go to work every morning, what do you look forward to?
I think the best part of my job I would describe as the children themselves. Despite facing such severe illnesses, some of which can be life-threatening, some of which can be chronic, so require very long-term treatment, the children are so inspiring. Compared to adults, they're much more enthusiastic. When you see them run around, when you see them face the challenges of the day-to-day treatment, you sometimes forget what they're going through. They have this unique ability to get up and bounce back so quickly. And that's what I find is the best part of my job, is to see those children, to meet them every day, and to try and help them get back to a normal part of their life.
Okay. And are a lot of these children, how many of these children are under chronic treatment as opposed to a short term, maybe, a couple months?
So it varies in different types of cancer. So to give you a perspective, for example, childhood leukemia treatment, the most common type of leukemia, acute lymphoblastic leukemia, the general duration of treatment is about 2 years and 1 month. Compared to brain tumor, for example, medulloblastoma, the treatment is anywhere between 4 to 6 months.
Oh, okay.
And also the part of the treatment involves many different modalities. It can involve surgery, chemotherapy, as well as radiation.
Oh, okay. So it's not just one specific type of treatment. Wow. No, I think it's very, very unique in the sense that we often just take it for granted that, cancer today has become such a common term, in a sense, that no one really pays attention to what exactly would be going on in people, involved with cancer, their family, their friends. And I think it's really unique that children, out of all people, have the ability to fight that type of cancer, which is probably just as harmful and probably just as dangerous as other types of cancers that adults face. Thank you for that. And going on to the contrary point of view, what are the challenges that you face with some of the diagnoses and treatment?
There's many challenges in terms of the medical aspect. Diagnosing can be a challenge because it's not always straightforward. The gold standard for diagnosing any tumor is having a piece of the tissue that has the cancer.
Right.
And that's not always simple as it sounds.
Mm-hmm.
Depending on the location, if it's a brain tumor that's deep down in the brain, it may not be accessible to get a biopsy or piece of the tissue. Sometimes it's in a location where doing the actual biopsy may cause more harm than just starting the treatment. So the actual diagnosis can be quite difficult, but we have evolved in our ways of diagnosing. When we do run into those challenges, we use compilation of different tests to come together, such as different blood tests or blood markers for cancer, such as imaging, so MRI or CT scan. There's other different types of scans, PET scans, bone scans, depending on the type of cancer that we're trying to diagnose, and eventually also biopsy or a piece of the tissue. So that's the medical aspect, I think, of diagnosis. Also, there's a lot of challenges in treatment because the biggest challenge in any treatment, it can be radiation or chemotherapy or surgery for that matter, is that we're not quite advanced to a point where the treatment can only target specifically the cancer cells. Right. Majority of our treatment modalities to date affect not only the cancer cells, but it also affects the healthy cells or the healthy parts of our body. So it leads to a significant amount of side effects in children and patients that we're treating. So that's always a challenge for us. We're moving towards a trend of what we call targeted therapy. So what you'll see in the future, in the coming years, which we have started already, is having specific or targeted therapy for different types of cancer that only affects those specific cells.
Right.
But we're not quite there yet.
Okay.
And the other huge aspect in our field, because it's children, the most precious entity of a family's life, of a parent's life. So the psychosocial aspect is huge in terms of grief, in terms of the shock of the initial diagnosis, the length of treatment, the children having to come to hospital so often, them not being able to do normal parts of their life, such as attending school, going out with their friends, and doing all the things that other healthy children do. So the psychosocial aspect is a huge challenge. And in that, sometimes can also be the financial aspects or social aspects of the family dynamics that can play into it. So those are some of the challenges we see in dealing with patients who have childhood cancer.
Right. Yeah. Again, it's so weird how you don't see a lot of you never think about this kind of thing, but when you have a different perspective to it, you can realize what it actually would be like, to be around someone who is diagnosed. So this brings us to the next point, is how exactly, you talked a little bit about, in future terms of cancer treatment, you have full
targeted therapy.
Targeted therapy, exactly. So with that, is it would you use the same kind of techniques? So for example, would you use MRI, so you use imaging, you use other type of techniques? Would you use it just for a targeted type of cancer, or would it include new techniques as well?
Yeah, so I think going forward in future and where we have come so far, we made progress in two ways, if I may lay it. The first is in trying to identify patients who are at higher risk and who are at lower risk.
Right.
Because when we started off in the 70s or 80s, we were going full force with treating children. And over time, we realized that some children may have a lower risk and their cancer may be easier to treat, so they may need less treatment.
Right.
Whereas other children may need more treatment. So I think we're becoming very good at identifying risk factors for figuring out which children will do well with less therapy and which children will do poor and will need more intensive therapy, including chemotherapy or radiation, for example.
Right.
So I think that's one part of the advancement we're making, trying to figure out genetic factors that make somebody a more poor prognosis versus a better prognosis, identifying certain blood tests, certain aspects of the cancer that we see in the tissue itself, and also how people respond to initial part of therapy that will tell us how they will do in the long run.
Right. Okay.
So I think that's the first aspect in figuring out who is at increased risk or who is destined to do well versus destined to do poorly. So I think that's the first major thing in the future. And the second thing is, when I say targeted therapy, basically we're figuring out on certain cancer cells specific antigens or specific markers that we have been able to design antibodies to, so that it would be specific for those kind of cells.
Right.
So to give one example, or one very common example, in patients with lymphoma that is of the B cell origin, amongst all the different types of cells in our immune system, we have B cells, and they are positive for a marker called CD20. And there is a common medication by the name of rituximab, which is an antibody to the CD20 marker. So in treating patients with the B cell lymphoma, we're now currently, there's a study underway looking at the effect of adding rituximab, which in a way is targeted therapy because it attacks all cells that have CD20, which would be majority of your lymphoma cells. So that is an example of targeted therapy. And in more and more types of cancers, we're discovering specific markers that we can design antibodies to, or that we can design antidotes to be able to target specific cancer cells.
Perfect segue to my next question to you is, where in the treatment and diagnosis aspect, where do you think the role of research, you touched on a little bit with this example, where the role of research and to a more general extent, awareness of cancer in the public makes plays a role?
The role of research is huge. It's phenomenal, especially in my field. In dealing with pediatric hematology and oncology, the numbers of patients that we see is not nearly to an extent that you see in the adult population. So in any one institution, in any one organization, we don't have enough number of patients to be able to treat them and learn from them. So there have been great efforts across North America and across the world to form collaborative research groups where we work together in treating specific cancers through specific protocols that are research-based, and we learn from them and we try to become better at treating different types of cancer. And to give you one example of such a collaborative group is called Children's Oncology Group, which was combined of two different groups that were in North America, which is now one large group consisting of almost 231 organizations or hospitals across the United States and Canada that work together to design research-based protocols for specific cancers, to learn not only about the best treatment, but also the best way to diagnose, to stratify based on certain risk categories, and also learn the side effects or long-term prognosis of different patients. So such collaborative efforts have helped significantly patients with childhood cancer. And I think the collaboration amongst the medical community, but also awareness in the public is very, very important. Because such research efforts require a lot of money as well. So the financial aspect it becomes a huge deal. So awareness amongst the public, awareness in the government, the lawmakers, the policymakers who are funding such efforts is paramount. And also certain organizations who are doing fundraising efforts,
Right.
Which allows the research to grow and for us to become better. And to give you an idea, pediatric oncology is one of the success stories in the 21st century. About 50 years ago, we were able to treat about 20% of children with cancer.
Oh, okay.
Today, that number has increased to about 80%.
Wow.
So all comers in pediatric oncology were able to treat 80% of the children, which is a huge success story. But there's ways to go.
Of course.
Not only the other 20%, but also to reduce the side effects.
Right.
And to learn more about the disease and also the treatment aspects. So we have a lot more work to do in the future.
Right. So I think we can really take pride in I definitely can, being part of SABCR. We are working towards, as you described, how research and the financial support is so monumental in that it creates the basis for advancing the type of treatment and the type of the easiness with which everything is treated in the hospitals, and also with the idea of awareness indirectly, as as we call it, the snowball effect. It rolls, and at the end of it, we get substantial results when we get down to the level of the hospital patient. So that was very insightful talk. Thank you.
Thank you for having me, and also certainly appreciate the great work that you guys are doing, especially among the students level in the university and in the community. It's very helpful in its own way. So keep up the good work.
So that ends our talk today, and we'll see you next time with the SABCR Brain and Health Talks. Bye.